Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam. Today we're going to be talking about clinical EKG interpretation. This is going to be based on my book, Clinical EKG Interpretation and Patient Management. You can check out a copy of this on Amazon.com. Please look at the chapters on introduction, electrical axis, conduction disturbances, bundle branch blocks, enlargements, and bradycardia, supraventricular tachycardia in other videos on our YouTube channel. In this presentation, we will be talking about myocardial ischemia and myocardial infarction. So let us begin. Here is a answer key that is used in cardiology boards. In this presentation, we will be focusing our attention on myocardial ischemia and infarction. We're going to look at the coronary anatomy and how it correlates to different regions of the myocardium and how an occlusion of a coronary artery can result in changes in a group of leads. We'll also look at ventricular ischemia, sub-endocardial myocardial ischemia or infarction, giant negative T waves, STT changes, and also talk about differential diagnosis of myocardial ischemia or infarction. Now let's focus on coronary anatomy. The heart is supplied by two major coronary arteries, namely the left coronary artery and the right coronary artery. The left main coronary artery arises from the left coronary sinus and it divides into the left anterior descending branch and the left circumflex trunk. The left anterior descending branch travels along the interventricular groove and it supplies the anterior, the septal, and the apical walls of the left ventricle. The left anterior descending artery gives rise to perpendicular branches which are known as septal branches that supply the interventricular septum between the two ventricles. Left anterior descending artery also gives rise to the diagonal branches which supply the high anterior wall and also the anterior wall involving the left ventricle. The circumflex trunk travels along the left atrioventricular groove and it gives rise to large marginal branches ranging from 2 to 4 which supply the lateral wall of the left ventricle. In 15% of the patients, the circumflex artery gives rise to a posterior descending branch which supplies the inferior wall of the left ventricle. Thus, an occlusion of a left anterior descending branch can result in an anteroseptal myocardial infarction, whereas occlusion of the circumflex trunk can result in infarction involving the lateral wall of the left ventricle. Now let's focus on the right coronary artery. The right coronary artery arises from the right coronary cusp and it traverses between the right atrium and the right ventricle. It gives rise to the marginal branches which are known as acute marginal branches which supplies the right ventricle. In addition to that, the right coronary artery, as it wraps around the heart and reaches the crux, it joins the distal branches of the circumflex trunk. The main branch from the right coronary artery, of course, is the posterior descending branch or the PDA, which supplies the inferior wall of the left ventricle and also the posterior wall of the left ventricle. Whenever there is an occlusion of a right coronary artery, it can result in an inferior myocardial infarction, and if there is an occlusion involving the proximal segment of the right coronary artery, we also may see involvement of the right ventricle or right ventricular infarction. So this is in a nutshell an overview of the coronary anatomy. However, if you look at a pathological specimen, you can see what we are seeing are just the epicardial arteries that are supplying the myocardium. In fact, there's a very rich network of arteries, arterioles, and capillaries that supply the entire myocardium. So it is not uncommon. We can see some diseases involving smaller branches which may not be amenable to any kind of interventional treatment. If we look at the cross section of the heart, here we have the left ventricle with the papillary muscles, the anterolateral and the posterior medial papillary muscles. Then we have the right ventricle here. And here is the anterior wall, and here we have the anteroseptal. Similarly, we have the infroseptal, the inferior wall. Then on the lateral side, we have the anterolateral and the infralateral myocardium. Thus, an occlusion of a left anterior descending artery results in an infarction involving the anterior and the anteroseptal wall, whereas occlusion of the right coronary artery can result in infarction involving the inferior wall of the left ventricle. A circumflex trunk occlusion can result in an infarction involving the lateral wall of the left ventricle. An electrocardiogram has 12 leads. Lead 1, 2, 3, AVR, AVL, AVF, V1 to V6. And when we have involvement of the high anterior wall, there may be an occlusion of a circumflex marginal or a diagonal branch that results in changes reflected in lead 1 and AVL. If there is an occlusion of the right coronary artery, especially the posterior descending branch, it results in inferior myocardial infarction, which is reflected in the leads 2, 3, and AVF. When there is involvement of the left anterior descending branch, we can see involvement of the septum and the anterior wall, which is reflected in leads V1 to V4. If there is occlusion of the circumflex trunk, that results in infarction in the lateral wall, which is reflected in leads V5 and V6. Combining the coronary anatomy and the leads, here's a composite chart. High anterior myocardial infarction is usually related to occlusion of a diagonal branch or a marginal branch from the circumflex trunk, and this results in changes in leads 1 and AVL. We already talked about the anteroseptal myocardial infarction, which is generally caused by occlusion of the left anterior descending artery, and it is reflected in leads V1 to V4. The lateral wall myocardial infarction is reflected in V5 and V6. Anterolateral can involve V1 to V6. The inferior myocardial infarction related to occlusion of the right coronary artery, or in 15% of the cases, it may be related to the circumflex distal branch occlusion, and this can result in changes in leads 2, 3, and AVF. Infraepical infarction may be seen, which may be reflected in leads 2, 3, AVF, and V3 and V4. Occasionally, we can see reciprocal changes in the anterior leads, namely V1 to V3, with tall R waves, ST depression, and upright, it should be ST depression, and upright T waves, which reflect posterior myocardial infarction. If you look at the heart here, in the chest, as it is sitting in the mediastinum, we see the right coronary artery here. Here we have the right atrium, the right ventricle, the left ventricle, and the left atrial appendage. The left anterior descending artery traverses between the two ventricles, and it gives rise to the septal and diagonal branches. Now let's look at some evolutionary changes of an acute myocardial infarction. When there is an occlusion of a coronary artery or one of its branches, there is straightening of the ST segment with the elevation of the J point. As the coronary artery occlusion continues, the ST segments are lifted from the baseline, resulting in an ST elevation or STEMI, along with the hyperacute T waves. So these We may see similar changes in patients with angina pectoris or in patients with princemetal angina where there is a coronary artery spasm. As the coronary occlusion continues, the ST segments become convex upward with the inversion of the T waves. If the occlusion continues for greater than 6 hours, there is a development of Q waves with loss of R waves and STT changes that were noted earlier. Over a period of 4 to 6 weeks, the ST segments return to the baseline and the T wave inversion may continue for weeks or months. If the ST segment remains elevated 6 weeks after an acute myocardial infarction, we should always consider the possibility of left ventricular aneurysm. If you look at an electrocardiogram in a patient who had a myocardial infarction in the past 12 months or 18 months, the changes that will be left that reflect old myocardial infarction may be the presence of pathological Q waves. I want to stress the word pathological because there are some non-diagnostic Q waves which we will be talking about later on. So in an old myocardial infarction, the only footprint that we may see may be the presence of a Q wave with loss of R waves of varying degrees. So these are the evolutionary changes of acute myocardial infarction from the time of onset of coronary occlusion to a time beyond 6 months to 12 months. There are two other types of myocardial ischemia or infarction we come across. They are sub-endocardial ischemia or myocardial ischemia. The sub-endocardial myocardial ischemia is characterized by ST depression and T wave inversion in groups of leads. If the ST depression and T wave inversion are associated with elevated cardiac enzymes, they may represent sub-endocardial myocardial infarction or NSTEMI. Similarly, we may see symmetrically inverted T waves all across the electrocardiogram, which suggest left ventricular myocardial ischemia. These changes are associated with elevated cardiac enzymes. They may represent non-transmural myocardial infarction. These represent the building blocks of diagnosing acute myocardial ischemia, myocardial infarction, old myocardial infarction, sub-endocardial myocardial ischemia or infarction, and myocardial ischemia or infarction. I talked about pathological Q waves and non-diagnostic Q waves. In order for the Q waves to be representative of a myocardial infarction, the Q waves in leads V2 and V3 have to be greater than 20 milliseconds, or the QS complex in leads V2 and V3 have to be greater than 20 milliseconds. If we see Q waves greater than 30 milliseconds or 0.1 millivolt deep in contiguous leads, such as this should be 2-3 AVF or V4 to V6 or 1 AVL and V6, then these Q waves are pathological. If R waves are greater than 40 milliseconds in V1 and V2 with the concordant positive T waves in the absence of a bundle branch block, these changes may also reflect involving the posterior wall. An absence of a pathological Q waves does not exclude myocardial infarction. In fact, almost 15 to 20% of the patients may lose their Q waves after a period of 6 to 12 months following a myocardial infarction if the infarction was involving a small region of the myocardium. Lead 3 often has Q waves that are non-diagnostic, and generally they are isolated and they are not related to the leads involving the inferior wall. Now we're going to look at random electrocardiograms and use all the knowledge that we have accumulated in trying to understand what are we dealing with. Are we dealing with a hyperacute myocardial infarction? Is this a recent myocardial infarction of greater than 6 hours? Is this a myocardial infarction that is of 6 to 12 weeks? Are we looking at an old myocardial infarction? So let us try to arrive at a diagnosis based on the information that we have covered in this presentation so far. First thing you want to see is where are the changes localized. As you can see, we see the hyperacute changes in lead 2, 3, 4, V5 and to a certain degree V6. There is, as I described before, the straightening of the ST segment. There are hyperacute T waves. Whenever we see tall peaked T waves, not only should we be considering the possibility of an acute myocardial ischemia or infarction, but also we should keep in mind the possibility of hyperkalemia, which can give rise to tall peaked T waves. However, in patients with hyperkalemia, the ST segments are generally isoelectric, so you do not see the ST segment elevation or the J point elevation in patients with hyperkalemia. Here we have hyperacute changes in V2 to V6, which represents the anteroseptal and lateral wall of the left ventricle. This is less than 6 hours duration because we don't see pathological Q waves in these leads at this time. There are tiny Q waves, but these are non-diagnostic Q waves. This is just related to the septal activation in a normal situation. Hence, it is important to not only look at the changes, but also look at the criteria that we use for diagnosing various stages of an acute myocardial infarction. Here we have another example. We have sinus bradycardia with ST elevation and J point elevation, but there is already the development of Q waves in lead V1 and V2. So this is a myocardial infarction of greater than 6 hours. It is not uncommon to see various types of conduction disturbances and heart blocks in patients with acute myocardial infarction, as the infarction may involve not only the myocardium but also the conduction system, as the conduction system is located inside the myocardium. Now here is an example of a patient with ST depression in 1 and in ABL and from V2 to V6. So these are the predominant findings in this electrocardiogram. According to the chart we just covered earlier, ST depression is representative of sub-endocardial myocardial ischemia. If this patient presents with chest pain and elevated cardiac enzymes, these changes are suggestive of sub-endocardial myocardial infarction involving the high anterior wall and the anterolateral walls. So there is almost evidence of global sub-endocardial myocardial ischemia or infarction based on the clinical presentation and the cardiac enzymes. Here is an example which is very similar to the one we just covered, with significant ST depression of almost 4 to 5 millimeters involving similar leads such as lead 1, AVL and V3 to V6. This is extensive anterolateral sub-endocardial ischemia. If this is associated with elevated cardiac enzymes, this represents a sub-endocardial myocardial infarction. Here is an example of ST elevation noted in leads 2, 3 and ABF, with the elevation of the J point and straightening of the ST segment. This represents the inferior wall of the left ventricle. However, if you look at the chest leads, they are labeled little differently. Here we have V1, V2, then it says V3R, then V4R, and up V5R and V6R. So these represent the right-sided chest leads. If you suspect there is involvement of the right ventricle or there is right ventricular myocardial infarction, if you do the right-sided chest leads, then you can see the classic ST elevation with the T-wave inversion. So this is an inferior myocardial infarction with involvement of the right ventricular free wall. In about 30% of the patients with the inferior myocardial infarction, we may see the evidence of right ventricular infarction. Especially if patients with the inferior myocardial infarction have persistent hypotension, then it is wise to perform an electrocardiogram involving the right-sided chest leads to see if there is evidence for involvement of the right ventricular free wall. Here is another example of ST elevation noted in lead 1, AVL, V1 to V4. Previously we saw significant ST depression. Now we are seeing ST elevation involving the high anterior and the anteroseptal regions of the left ventricle. Along with that, we see ST depression in the inferior leads, and these are known as reciprocal ST depressions, and we see them in the leads that are opposite to the region of the myocardium involved in an acute coronary ischemia. So here we have an high anterior and anteroseptal hyperacute myocardial infarction. There is already the presence of Q waves, which means this myocardial infarction is probably greater than 6 hours in duration. What is your diagnosis? You can pause here and come up with a diagnosis, then we'll continue. We have a sinus rhythm, and we have ST elevation and hyperacute T waves. There are some tiny Q waves noted in V1, V2, V3 and V4. This is an example of an anteroseptal myocardial infarction which is hyperacute in nature and maybe perhaps greater than 6 hours in duration. Here we see J point elevation, straightening of the ST segment and hyperacute T waves involving leads 2, 3, ABF. And we see reciprocal changes in lead 1 and ABL. Along with that, we see an additional feature here, and that is the presence of R waves, ST depression and upright T waves in leads V2 and V3. Here we are dealing with an acute inferior myocardial infarction. This is hyperacute with reciprocal changes in leads 1 and ABL, along with the posterior wall involvement. The changes we are seeing in lead V2 and V3 are a mirror image of these hyperacute changes. This involves the posterior wall of the left ventricle. Here is another example of an isolated posterior myocardial infarction, because we see tall R waves with ST depression and upright T waves. If you were to hold a mirror here, you will see they look like hyperacute changes of a myocardial infarction. And since this is involving the posterior wall, we are seeing a mirror image of the hyperacute changes. Here we see an example of an old inferior myocardial infarction, because we see pathological Q waves, loss of R waves, along with flat ST segment and T waves. On the other hand, in the leads V1 to V5, we see ST elevation with Q waves. So we see a recent anteroseptal myocardial infarction. Here's another example of acute inferior myocardial infarction involving leads 2, 3, AVF with reciprocal ST depression in leads 1 and AVL, along with some posterior wall involvement characterized by ST segment depression, R waves, and upright T waves. So this is an infero-posterior myocardial infarction with reciprocal changes noted in lead 1 and AVL. Now we see something different here. Can you recognize the change? There are deeply inverted T waves in multiple leads involving the inferior wall, the anteroseptal, and the lateral wall. This is like almost global myocardial ischemia. These deeply inverted T waves represent myocardial ischemia, and if these changes are associated with elevated cardiac enzymes, this represents non-transmural myocardial infarction or NSTEMI. Whenever we see deeply inverted T waves in multiple leads, we should also consider the differential diagnosis of cerebrovascular accidents. Now here's an example of a horizontal ST depression noted in the lateral chest leads. This is suggestive of sub-endocardial myocardial infarction. These are not secondary changes related to left ventricular hypertrophy, where you will see an ST segment which is coving upwards with T wave inversion, but here we are seeing horizontal ST depression, which is more characteristic of sub-endocardial myocardial ischemia. And if this is associated with elevated cardiac enzymes, it represents sub-endocardial myocardial infarction or NSTEMI. Here we have a 25-year-old male who came for a routine school sports, or you should say college sports check. And the obvious findings in this electrocardiogram are ST elevation of maybe a millimeter noted in leads 2, 3, AVF, and also in the chest leads. This is an example of early repolarization, which is one of the differential diagnoses for acute myocardial ischemia or infarction. However, the ST changes we see here are quite different from the ST changes we saw in a hyperacute phase of a myocardial infarction. Here the ST segments are concave upwards, and generally the T waves are not as peaked as we would see in patients with acute myocardial ischemia. The other important point is that these changes are generalized and they are not localized to a particular region of the left ventricle. Here we have hyperacute ST changes in lead 2, 3, AVF with reciprocal changes in lead 1 and AVL. In addition to that, we also have involvement noted in the right chest leads. As you can see, there's a right R which represents right chest leads. So here we are looking at another example of a inferior myocardial infarction involving leads 2, 3, AVF along with right ventricular infarction. So always keep in mind, if you are dealing with a patient with inferior myocardial infarction who is unstable, do the right-sided chest leads to see if you are dealing with a patient with right ventricular infarction. This can also be confirmed with echocardiogram, which may show changes in the right ventricular size and function. What is your diagnosis? First, we need to isolate the most prominent findings. Here we see ST elevation in leads 2, 3 and AVF, which represent hyperacute changes of an acute inferior myocardial infarction. Along with that, we have what appears to be ectopic beats appearing after each normal beat. So here we are dealing with a ventricular bigeminae. We also see some ST depression and upright T waves, which may suggest some degree of involvement of the posterior wall, even though not obvious as we saw in the previous examples. Now, in this electrocardiogram, we see ST elevation in lead 1, AVL, which represent the high anterior wall. Then we have ST elevation in V1 to V4, predominantly and to a certain degree in V5, and this may represent high anterior and anteroseptal myocardial changes, along with some reciprocal changes of ST depression noted in leads representing the inferior region of the left ventricle. This is an interesting electrocardiogram which shows ST depression with tall upright T waves in the anterior leads V2, V3, V4, V5. When we see these changes, this represents in many cases occlusion of a proximal left anterior descending artery, and these changes were first described by Dr. Winters, and these are known as D. Winters STT changes. So whenever you see this pattern, always think about occlusion of a proximal left anterior descending branch. Here we have a 45-year-old male with chest pain. We see ST elevation, but they are present in multiple leads. The inferior leads, the high anterior leads, and also the lateral leads. But the ST segments are concave, facing upwards. So this may represent acute pericarditis, and these STT changes are different from the hyperacute changes we saw in transmural myocardial infarction. Here's an example of diffuse T-wave inversion involving 2-3 AVF and V2 to V6. This is representative of left ventricular ischemia, and if this is associated with elevated cardiac enzymes, it represents non-transmural myocardial infarction or NSTEMI. Here we have an example of a ST elevation in lead 1 AVL, which represents the high anterior wall, along with what appears to be like tombstones. So these are called tombstone T waves. We see them in leads V2 to V5. So this represents an acute myocardial infarction involving the high anterior and the anterolateral wall of the left ventricle. By the same token, these tombstone T waves represent grave prognosis because of involvement of the proximal left anterior descending artery, along with extensive myocardial damage that can reduce the left ventricular function and reduce the prognosis of a patient with this type of EKG changes. Here we see Q waves with right bundle branch block and T wave inversion. This is an example of a septal myocardial infarction with the presence of a right bundle branch block. There is also some evidence of inferior Q waves or maybe RS complex. So this is not really diagnostic of inferior myocardial infarction because of the presence of tiny R waves noted in leads 3 and AVF. Here we see dramatic ST depression in lead 1, AVL, V4 to V6. So we have high anterior and lateral sub-endocardial myocardial ischemia or infarction, along with a premature ventricular beat and some degree of ST elevation noted in the leads 3 and AVF. This is just to re-emphasize the fact that in patients with pericarditis or early repolarization, we see an ST segment which is concave looking upwards, whereas in patients with acute myocardial infarction, we see elevation of the J point, straightening of the ST segment with tall peak T waves. Here we see an example of a left bundle branch block. Sometimes it is very challenging to diagnose the presence of a myocardial ischemia or infarction in patients with the left bundle branch block. We already have STT changes related to the bundle branch block. In addition, it is not uncommon to see ST elevation or the J point elevation in patients with the left bundle branch block, and this J point elevation could range from 1 to 5 or 10 millimeters in certain cases. So how do we diagnose the presence of an acute myocardial ischemia or infarction in patients with the left bundle branch block? There are certain findings which we can use to diagnose the presence of acute myocardial ischemia or infarction in the presence of left bundle branch block. Garbosa came up with these criteria to diagnose the presence of a myocardial ischemia or infarction in patients with a left bundle branch block. In patients with a left bundle branch block, if we see ST segment elevation of greater than 1 millimeter and in the same direction, that is concordant with the QRS complex, it accounts for 5 points. If there is ST depression of greater than 1 millimeter in leads V1, V2 and V3, it accounts for 3 points. If we see ST elevation of greater than 5 millimeters in the opposite direction of the QRS complex, it accounts for 2 points. You need 3 points to diagnose an acute myocardial infarction. Now let's talk about differential diagnosis of acute myocardial infarction. Hyperkalemia can mimic acute myocardial infarction. Pericarditis, which we already talked about, can mimic acute myocardial ischemia or infarction. Left bundle branch block, which I just mentioned. Patients with a chronic obstructive pulmonary disease may have loss of R waves anteriorly along with low QRS voltage, and that may represent an anterior myocardial infarction. Patients with WPW or Wolff-Parkinson-White syndrome may mimic both inferior and anterior myocardial infarction. Similarly, left anterior hemiblock with the deep RS or QS complexes in leads 3 and AVF may mimic inferior myocardial infarction. Now here is an example of a left bundle branch block. As I mentioned before, we see ST elevation of almost 4 to 6 millimeters in the anterior leads along with STT changes. However, the ST depression of almost 3 millimeters here is pathological, because you generally don't see this degree of ST depression related simply to the left bundle branch block. So by using Garbosa criteria, we can still diagnose the presence of myocardial ischemia or infarction if we follow the guidelines which we just talked about. And here is an example of tall peaked T waves which are related to hyperkalemia, and this may mimic acute changes of a myocardial infarction. Whenever you see an electrocardiogram with the tall peaked T waves in the emergency room, the first thing that should come to your mind is hyperkalemia. If they are associated with significant ST elevation and straightening of the ST segment, then it may represent hyperacute changes of myocardial ischemia or infarction. But in patients with hyperkalemia, the ST segments are generally towards the baseline with a concave appearance of the ST segment. Here we have ST elevation noted in multiple leads involving the inferior wall, the high anterior and the anterolateral region. However, the ST segments are concave facing upwards. So this is an example of a patient with diffuse pericarditis, which may mimic acute myocardial ischemia. As I previously told you, if you see diffuse symmetrically inverted T waves in multiple leads, we should not only consider the possibility of left ventricular ischemia, but also patients with cerebrovascular accidents. Here's an example of a patient with chronic obstructive pulmonary disease. There is evidence of low voltage noted in the limb leads and also in the chest leads. There is also evidence for right axis deviation, peaked T waves representing right atrial enlargement, along with loss of R waves. However, there is still the presence of tiny R waves in the anterior leads. Nonetheless, this poor R wave progression may be related to right ventricular hypertrophy, but they may give you a suggestion of an anterior myocardial infarction. Hence, whenever you look at an electrocardiogram, it is important to put all the points together to see what are the predominant findings that we see in a given electrocardiogram. And this is a classic example of a patient with a COPD with right axis deviation, right atrial enlargement, along with the right ventricular hypertrophy, as we see S waves going all the way to the lateral chest leads. In this example, we see short PR interval with a delta wave. So we are dealing with WPW, and here we see QS complexes in lead 3 and AVF mimicking inferior myocardial infarction. We can also see deep QS complexes in the anterior leads in patients with WPW that may mimic anterior myocardial infarction. So, ladies and gentlemen, this is an overview of coronary anatomy, myocardial ischemia, myocardial infarction, sub-endocardial myocardial ischemia or infarction, and myocardial ischemia and infarction, along with some differential diagnosis. And in the next presentation, we will be talking about STT abnormalities, which are not only caused by myocardial ischemia or infarction, but also by a variety of conditions, some of which we have already touched upon in this presentation. Please visit Amazon.com and take a look at our book on clinical EKG interpretation and patient management. Thank you so much for your attention. I am Dr. Nik Nikam, and please do subscribe to our YouTube channel and watch other videos we have on EKG interpretation. Along with that, we also have more than 140 video presentations on various cardiovascular topics, and please do watch them. We will see you next time.